The chapter 45th of your Apurba Sastry Essentials of Microbiology, which is about intestinal protozoan infections. In this chapter, we will be previewing intestinal amoebiasis, intestinal flagellate infection like Giardiasis, opportunistic intestinal coccidian parasitic infections, and other intestinal protozoan infections. In this chapter, we will be covering the intestinal amoebiasis and intestinal flagellate infection, which is Giardiasis, and while the further two topics will be covered in the subsequent videos. The protozoan parasites which cause intestinal infections include intestinal amoebae like Entamoeba histolytica, intestinal flagellate like Giardia lamblia, opportunistic intestinal coccidian parasites like Cryptosporidium, Cyclospora and Cystoisospora. Others like Valentinum coli, Blastocystis hominis and Sacrocystis and Macrosporidia now considered as fungi. Entamoeba histolytica and Valentinum coli produce dysentery, whereas the other intestinal protozoans produce diarrheal diseases. Intestinal amoebiasis. Amoebae, meaning change, are single-celled protozoan parasites that constantly change their shape, which is due to the presence of an organ of locomotion called a pseudopodium. Based on the habitat, there are of two types: intestinal amoebae and free-living amoebae. Intestinal amoeba, Entamoeba histolytica, is the most important pathogenic intestinal amoeba. Most other species of Entamoeba are harmless, common cells in human intestine, example Entamoeba coli. Free-living amoebae. They are small, free-living, widely distributed in soil and water, and can cause opportunistic infection in humans, affecting central nervous system. Important human pathogenic free-living amoebae are Naegleria, Acanthamoeba, and Balamuthia. Entamoeba histolytica infections. Entamoeba histolytica causes amoebic dysentery and a wide range of other invasive diseases, including amoebic liver abscess. There are three other species of Entamoeba, such as Entamoeba dispar, Entamoeba moshkowski, Entamoeba bangladeshi, which are morphologically similar to Entamoeba histolytica, can be differentiated from each other by molecular and other methods described later. All of them are found as common cell in human intestine. Entamoeba moshkowski and Entamoeba bangladeshi are reported to be associated with infantile diarrhea. Epidemiology. Entamoeba histolytica is worldwide in distribution but more common in tropical and subtropical countries. The largest burden of disease occurs in tropics of China, Central and South America, and Indian subcontinents, affecting 10% of world's population, 500 million. It is the third most common parasitic cause of death in the world after malaria and schistosomiasis. Globally, approximately 50 million cases of intestinal amoebiasis with 1,10,000 deaths have been reported annually. In India, it has been reported throughout with the prevalence rate of 15%, ranges from 3.6 to 47.4%. Morphology. Entamoeba histolytica exists as three stages. Trophozoite is the invasive form as well as the feeding and replicating form of the parasite found in the feces of patients with active disease. It measures 15 to 20 micrometer in size, contains a single nucleus. It possesses finger-like projections called as pseudopodia which help in locomotion. Pre-cyst is the intermediate stage between trophozoite and cyst. Cyst is the diagnostic form of the parasite found in the feces of carriers as well as patients with active disease. These measure 12 to 15 micrometer in size, contain 1 to 4 number of nuclei. Cyst can be either immature or mature. Immature cyst contains 1 or 2 nuclei, whereas the mature cyst is quadrinucleated and is the infective form of the parasite. The morphological forms have been described in detail subsequently under the lab diagnosis. Now in this figure we can see the Entamoeba histolytica. A shows trophozoite stage with the pseudopodium, ectoplasm, WBC, endoplasm, karyosome which is central, peripheral chromatin granule which is fine, RBC and food vacuoles. The figure B shows pre-cyst stage, figure C shows uninucleated cyst, then binucleated and quadrinucleated cyst. The uninucleated cyst shows one nucleus with chromatid body and glycogen mass, while the bi and quadrinucleated shows 2 and 4 nuclei respectively. Life cycle. Entamoeba histolytica completes its life cycle in a single host, that is man. Infective form. Mature quadrinucleated cyst is the infective form, however immature cyst can also be infective. Mode of transmission. Entamoeba histolytica is transmitted by fecal-oral route, most common by ingestion of food or water contaminated with mature quadrinucleated cyst. Sexual, anogenital or orogenital contact, very rarely by vectors. Flies and cockroaches may mechanically transmit the cyst from feces and contaminate the food and water. Development in human intestine. Small intestine cysts bypass gastric juice and reach the small intestine where they undergo excistation. The cyst wall gets lysed by trypsin and 4 small trophozoites are released. Large intestine. Trophozoites are carried to the ileocecal region of the large intestine where they multiply by binary fission and then colonize the intestinal mucosa. After colonization, trophozoites show different courses depending on the host susceptibility. Asymptomatic cyst passers. In majority of individuals, trophozoites do not cause any lesion, transform into cyst and are excreted in feces. Amoebic dysentery. In some individuals, the trophozoites adhere to intestinal mucosa, producing intestinal ulcers and dysentery. Invasive amoebiasis. Very rarely, trophozoites invade intestinal mucosa, gain access to the portal veins, and migrate to extraintestinal sites. Most common site being the liver, where they cause amoebic liver abscess. Encystation. When the intestinal lesions start healing and patient improves, the trophozoites transform into pre-cyst, then into cyst, which are liberated in feces. Encystation occurs only in the large intestine. Cysts are never formed once the trophozoites are excreted in stool. Cysts released in feces can survive in the environment and become the infective form. Trophozoites are also excreted by uh, disintegrated disintegrated either in the environment or by gastric juice when ingested. Now, the virulence factor. Trophozoite of Amoebiasis histolytica is the invasive form and possesses many virulence factors that play an important role in the pathogenesis. Amoebic lectin antigen. It is a 260 kilodalton galactose and N-acetyl galactosamine inhabitable surface protein, gal-NAT-lectin, present on the surface of trophozoites. It is principally virulence factor. Helps in adhesion by binding to glycoprotein receptors on large intestinal epithelium and vascular endothelium. Other virulence factors include amoeba pore. It forms pore on the target cell membrane, causing leakage of ions. Cysteine proteases and hydrolytic enzymes help in invasion by the destruction of the target tissue, and neuraminidase and metallocollagenase help in invasion. In this figure, we can see the life cycle of Amoeba histolytica. Starting from, man acquires infection by ingestion of food or water by contaminated with quadrinucleated cyst. Next occurs excistation in small intestine in which trophozoites are released. These are carried to the large intestine in which trophozoites colonize on large intestinal mucosa. They can penetrate intestinal wall and are carried to extraintestinal sites like liver abscess and can cause liver abscess. Now, the trophozoites of the intestinal mucosa undergo encystation in which cysts are formed which are immature and mature. These cysts are released in feces, and mature cysts again can cause infection in man. Now, from the large intestinal mucosa, few trophozoites are released in feces also, but they get disintegrated. Next, coming on to the pathogenesis. The pathogenesis of intestinal amoebiasis occurs through the following steps. Colonization. Trophozoites first colonize the intestinal mucosa, facilitated by bacterial flora which lowered the oxygen tension. Adhesion. Then the trophozoites penetrate the mucous layer and adhere to the large intestinal mucosa by means of gal or gal-NAC lectin molecules. Flask-shaped ulcers. Trophozoites produce characteristic flask-shaped ulcerative lesions, broad base with a narrow neck and large intestine, most common site being the cecum. Ulcers are usually small, round to oval, scattered with intervening normal mucosa. They may be superficial or deep, size ranging from pinhead to inches. Invasion. Amoebae then invade the large intestinal wall, migrate to extraintestinal sites. The invasion is facilitated by cysteine proteases and hydrolytic enzymes secreted by Amoeba histolytica. Intestinal complications. Trophozoites may produce various intestinal complications. Complications of intestinal amoebiasis. Local migration of trophozoites may produce various intestinal complications like fulminant amoebic colitis results from generalized necrotic involvement of entire large intestine. Occurs more commonly in immunocompromised patients and in pregnancy. Amoebic appendicitis results when the infection involves the appendix. Intestinal perforation and amoebic peritonitis, toxic megacolon and intussusception. Amoebiasis cutis or cutaneous amoebiasis is a virulent form of amoebiasis present as perianal skin ulcers as extension of amoebic colitis may also be seen following anal intercourse. Amoebema or amoebic granuloma, a diffuse pseudotumor like mass of granulomatous tissue found in rectosigmoid region. Chronic amoebiasis, it is characterized by thickening, fibrosis, structure formation with scarring. Coming on to the clinical manifestations, incubation period varies from 1 to 4 weeks. Males and females are affected equally. Majority of the infection, 90%, result in asymptomatic cyst passers. The remaining 10% develop intestinal amoebiasis characterized by amoebic dysentery. Symptoms include bloody diarrhea up to 10 times per day with mucus and pus cells, colicky abdominal pain, fever, prostration, and weight loss. Amoebic dysentery should be differentiated from bacillary dysentery. Amoebic appendicitis presents with acute right lower abdominal pain. Amoebema presents as palpable abdominal mass. Fulminant colitis presents as intense colicky pain, rectal tenesmus more than 20 motions per day, fever, nausea, anorexia, and hypotension. Now, in this figure, we can see the complications of intestinal amoebiasis, the cross section of the intestinal wall. Starting with a flask-shaped ulcer within the mucosa and the just above the muscularis mucosa, then it forms the sinus with a deep extension of ulcer beyond the muscularis mucosa. Finally, it does perforation of the intestine. Amoeboma is formed and invasion of blood vessels can also be there. Okay. Now the differences between the stool characters between amoebic dysentery and bacillary dysentery. Ulcer in amoebic dysentery is deep while shallow in bacillary. Margin in amoebic is ragged and undetermined while uniform in bacillary. Intervening mucosa is normal in amoebic while inflamed in bacillary. Cellular response is mononuclear in amoebic while polymorphonuclear in bacillary. Stool macroscopic feature, number of motions 6 to 10 per day in amoebic while more than 10 per day in bacillary. Amount, copious amount in amoebic while small quantity in bacillary. Color, dark red in amoebic while bright red in bacillary. Offensive odor in amoebic while odorless in bacillary. Reaction, acidic in amoebic while alkaline in bacillary. And consistency, non-adherent to the container in amoebic and adherent to the container in bacillary. Stool microscopic feature, RBCs in clumps in amoebic while discrete or in rolex in bacillary. Pus cells few in amoebic while numerous in bacillary. Macrophages few in amoebic while numerous in bacillary. They may contain RBC also, so they can be mistaken as trophozoites. Okay. Eosinophils present in amoebic, absent or rare in bacillary. Charcot-laden crystal present in amoebic, absent in bacillary. Pycnotic body, which are the nuclear remnants of tissue, cell and leukocytes, are present in amoebic while absent in bacillary. Organism detected in amoebic is of course Entamoeba histolytica cyst or trophozoite, while it is a bacteria, example Shigella in the bacillary. Now coming into the lab diagnosis of intestinal amoebiasis, stool microscopy by wet mount, permanent stains, etc. detect cyst, round 1 to 4 nuclei and trophozoites with finger-like pseudopodia. Histology, intestinal biopsy stained with PAS or HNE stains reveal trophozoites. Stool culture, polyxenic and axenic culture. Stool antigen detection, Cobro antigen. ELISA detecting 170 kilodalton of lectin antigen and ICT detecting 29 kilodalton surface antigen. Serology, amoebic antigen ELISA 170 kilodalton of lectin antigen, amoebic antibody ELISA. Isoenzyme zymodine analysis, molecular diagnosis, nested multiplex PCR and real-time PCR 18S rRNA and biofire film array. Lab diagnosis, sample collection. Stool is the specimen of choice. Minimum of 3 stool samples should be collected on alternate day within 10 days as amoebae are shed intermittently. Other samples include rectal exudates and rectal ulcer tissues collected by colonoscopy. It should be examined immediately within 1 to 2 hours of collection or can be preserved in merthiolate iodine or formalin. However, refrigeration is not recommended. Stool macroscopy. Stool is foul smelling, copious in amount, dark red in color, mixed with blood and mucus and not adherent to the container. It should be differentiated from bacillary dysentery where the stool is bright red, odorless and adherent to the container. Stool microscopy. Direct examination of the stool from blood streaked area by saline and iodine mount is performed to demonstrate trophozoites and cysts. Microscopy is poorly sensitive 25 to 60% with single sample, but the sensitivity increases to about 90% when 6 stool samples are examined. The sensitivity can be further improved by examining the stool samples after concentration by formalin ether sedimentation method. Stool can also be examined by staining with permanent stains like trichome stain and iron hematoxylin stain. Internal structure of cyst and trophozoites are well demonstrated by permanent stains. Reporting. Cyst and trophozoite of Entamoeba histolytica are indistinguishable from that of Entamoeba dispar and Moszkowski or Entamoeba bangladeshi, except for the presence of RBCs in the trophozoites of Entamoeba histolytica, which might not be there after the dysentery episode is over. So, the report should always be sent as cyst or trophozoite of Entamoeba histolytica, Entamoeba dispar, Entamoeba moscovici, or Entamoeba bangladeshi are found in the stool microscopy. Now coming on to the trophozoites, demonstration of trophozoite in freshly passed stool is considered as gold standard microscopic test for active infection. They are not found in stool of asymptomatic carriers. Measures: 15 to 20 micrometer has cytoplasm divided into a clear ectoplasm and a granular endoplasm and single nucleus. Motility: they are widely actively motile with finger-like pseudopodia which exhibit active, unidirectional, rapid, progressive and purposeful movement. Hematophagous trophozoite, presence of ingested RBCs in cytoplasm is a feature of Entamoeba histolytica being invasive, which differentiates it from Entamoeba dispar. Nucleus: it has a central karyosome and fine peripheral chromatin granule lining the nuclear membrane. The space between the karyosome and the nuclear membrane is traversed by spoke-like radial arrangement of achromatic fibrils, cartwheel appearance. Nucleus is seen as a faint outline in the saline mount but better appreciated in permanent staining. Trophozoites are better appreciated in saline mount than iodine mount, as iodine kills the trophozoites and motility cannot be appreciated. Therefore, trophozoites should not be reported based on iodine mount. Now, the quadrinucleated cyst. Cysts are found in stool specimens of both patients with active infection and carriers. The internal structure of cyst is clearly appreciated by iodine mount than saline mount and even better on permanent staining. Cysts appear round, 12 to 15 micrometer in size, containing 1 to 4 nuclei. The appearance of nucleus is described for trophozoites. Both mature cysts contain 4 nuclei and immature cysts contain 1 or 2 nuclei are found in stool. Cytoplasm of uninucleated cyst contains few chromatoid bodies, aggregation of ribosome and a large glycogen mass, stains brown with iodine. Histology. Trophozoites can be detected in sigmoidoscopy guided biopsies collected from at least 6 areas of colonic mucosa and stained with periodic acid Schiff, PAS or H&E stains, or ideally with peroxidase staining with anti-E histolytica antibodies. Stool culture. Culture methods are not routinely used for diagnosis, show 50 to 70% sensitivity and 100% specificity. They are useful in studying pathogenicity of the amoeba for preparation of amoebic antigen for serological test, research and teaching purposes. Various culture media include polygenic culture. This culture medium contains bacterial supplement, starch and serum providing nourishment to the amoeba. Various culture media used are National Institute of Health NIH media, Boeck and Darbolev egg serum medium containing LOX solution, axenic culture, it lacks bacterial supplement, example diamonds medium. Stool antigen detection, coproantigen. As amoebic antigen get denatured by stool preservatives, only fresh or frozen stool samples should be used. Various tests used to detect antigens in stool are ELISA detecting 170 kilodalton of the lectin antigen. It shows more than 95% sensitivity and specificity. It can also differentiate pathogenic Entamoeba histolytica lectin antigen positive and non-pathogenic Entamoeba dispar lectin antigen negative. Immunochromatographic test ICT is a rapid diagnostic test, give result within 20 to 30 minutes. Triage parasite panel, it is a cartridge based commercially available ICT, shows 83 to 96% sensitivity and 99 to 100% specificity. It simultaneously detects 3 parasitic antigens in stool. Giardia lamblia alpha 1 Giardian antigen, Entamoeba histolytica or Entamoeba dispar 29 kilodalton surface antigen. It cannot differentiate Entamoeba histolytica from Entamoeba dispar as both express this antigen. Cryptosporidium parvum protein disulfide isomerase antigen. Now coming on to the figures. Figure 45.4a to D show Entamoeba histolytica trophozoites. A shows it in saline mount. B and C shows trichome stain on there is a single nucleus RBC and ectoplasm and endoplasm. Okay, and figure D shows trophozoites in colon tissue stained with H&E stain. Figure 45.5a to C shows the cyst of Entamoeba histolytica, A in saline mount, B in iodine mount, and C is the trichome stained smear. Note that the chromatid body with blunt ends. Okay. Figure 45.6 shows Tide's parasite panel positive for Entamoeba histolytica or Entamoeba dispar antigen. Coming on to serology. Amoebic antigen. Amoebic antigen in serum is found only in patients with active infection and disappears after clinical cure. So its presence in serum indicates recent and active infection. ELISA is available detecting 170 kilodalton of lectin antigen, usually positive in the early stage of disease, sensitivity of 65%. ELISA is also available detecting various other antigens like serine-rich Entamoeba histolytica protein SREHP, lysine-rich surface antigen, etc. Amoebic antibody. ELISA is available detecting serum antibody IgG against the lectin antigen. Antibodies appear only in the later stages of the intestinal amoebiasis and therefore are not much useful in diagnosis. Isoenzyme zymodeme analysis. When isoenzymes of Entamoeba histolytica are subjected to electrophoresis, several zymodeme patterns can be produced. It can differentiate Entamoeba histolytica from Entamoeba dispar as both produce distinct zymodeme patterns. However, this method is difficult to perform, technically demanding, and time consuming and therefore not routinely used. Molecular diagnosis. Molecular methods have emerged as the gold standard test for the diagnosis of amoebiasis. Nested multiplex PCR is available targeting small subunit RNA genes. It can differentiate between Entamoeba histolytica, Entamoeba dispar, and Entamoeba moschkowski with a sensitivity nearing 90% and specificity of 90 to 100%. Real-time PCR targeting 18S RNA gene can be used as an alternative to the conventional PCR. It is more sensitive, can quantitate the parasite load, and takes less time than conventional PCR. Biofire Film Array is a fully automated commercial PCR system from Biomerics. Its gastrointestinal panel is used to detect common bacterial, viral, parasitic like Cryptosporidium, Cyclospora, Entamoeba histolytica, Giardia, diarrheal pathogens. Other non-specific findings, imaging methods, colonoscopy can be performed to detect collar button or flask-shaped amoebic ulcers. Charcot-laden crystals in stool, they are diamond-shaped eosinophilic breakdown products found in stool in some cases. Moderate leukocytosis in blood is also seen. Now, the treatment of intestinal amoebiasis, asymptomatic carriage treatment helps in reducing passage of cyst in stool and thereby preventing this disease transmission. Luminal agents are used for treatment. Idoquinol for 20 days or paromomycin for 10 days is used. Amoebic dysentery treatment consists of tissue agents, metronidazole for 5 to 10 days or tinidazole for 3 days plus luminal agents as above. Other measures include fluid and electrolyte replacement and symptomatic treatment. Now, the preventive measures are as follows: avoiding ingestion of food and water contaminated with human feces and treatment of asymptomatic carriers. Now, coming on to amoebae morphologically resembling Entamoeba histolytica. E. dispar, E. moschkowski, and E. bangladeshi are the amoeba which are morphologically both cyst and trophozoite similar to that of Entamoeba histolytica. Entamoeba dispar is a non-pathogenic commensal found in human intestine. Entamoeba moschkowski is primarily a free-living amoeba found in polluted water, may cause occasionally non-invasive diarrhea in infants. E. bangladeshi have been recovered from asymptomatic individuals as well as those with diarrhea. Diagnosis, they can be differentiated from Entamoeba histolytica by various methods like PCR amplifying small subunit RNA gene is the most reliable method. Detection of lectin antigen in stool, RBC inside trophozoites present only in Entamoeba histolytica, which is a marker of invasiveness. And zymodeme study can also be done. Now, the non-pathogenic amoebae, there are many non-pathogenic amoeba that may be found as harmless commensals in human intestine. Examples include Entamoeba coli, Entamoeba hartmanni, Entamoeba gingivalis, Entamoeba polki, and Endolimax nana, and Iodamoeba bacilli. Entamoeba coli is the most common non-pathogenic amoeba that colonizes the large intestine. It is frequently found in stool samples of healthy individuals and should be differentiated from that of Entamoeba histolytica. Okay, now we can see in these figures Entamoeba coli. Uh, Figure A shows the trophozoites while B and C show the precyst and cystage. In trophozoite, we can see ectoplasm, karyosome, which is eccentric, peripheral chromatin granules, which are coarse, food vacuole, and endoplasm. In quadrinucleated cyst and uninucleated one, we can see the glycogen mass with a filamentous chromatid body, while in octanucleated mature cyst, we can see 8 nuclei. Okay. Now coming on to the second part, which is intestinal flagellate infections. Giardia lamblia is a classic example of intestinal flagellate associated with diarrheal manifestation. It bears flagella as the organ of locomotion. Giardiasis. Giardiasis is caused by Giardia lamblia, also called as Giardia intestinalis or Giardia duodenalis. It was first observed by A.V. Leeuwenhoek in 1681 while examining his own stool. Later, it was described and named after Dr. F. Lambel and Professor A. Giard. Now, epidemiology. Giardia lamblia is the worldwide in distribution. It is considered as one of the most common parasite, causes both endemic and epidemic intestinal disease and diarrhea. Geographical area more common in warm climate of tropics and subtropics. India prevalence in children ranges from 0.5 to 70%. Zoonotic potential. Giardia has low zoonotic potential, infecting many mammals. Outbreak of giardiasis reported in Canada has been linked to beavers. Hence, the disease is also called beaver fever. Genotypes. Giardia has been classified into genotype A and B, which are further classified into 8 assemblages A to H. Human infections are caused by assemblages A and B. Assemblage B is common from South Asia, including India, whereas assemblage A is more common in Africa. Morphology. Giardia inhabits in crypts of duodenum and upper part of jejunum in man. It occurs in two forms. Pear-shaped trophozoite is the pathogenic form and feeding stage of the parasite, and the tetranucleated oval cyst is the infective form as well as the diagnostic form of the parasite. Now, some differences between Amoebiasis histolytica and coli. Okay, these were left. So, okay, let us discuss them. Trophozoite of histolytica is 15 to 20 micrometer, while coli is 20 to 25 micrometer. Motility of Amoebiasis histolytica is very active, unidirectional, purposeful motility, pseudopodia with finger-like projection. While that of coli is sluggish, non-purposeful and aimless motility in any direction, blunt pseudopodia are present. Histolytica cytoplasm clearly differentiated into ecto and endoplasm, while not so differentiated in case of coli. Cytoplasmic inclusions are RBCs, leukocytes, and tissue debris and bacteria in case of histolytica, whereas same except it does not contain RBC in coli. Nucleus karyosom is small and central. Nuclear membrane is thin and lined by fine chromatin granules in Amoebiasis histolytica, while that of coli, karyosom is large and eccentric. Nuclear membrane is thick and lined by coarse chromatin granules. Coming on to cyst comparison of Amoebiasis histolytica is 12 to 15 micrometer, while that of coli is 15 to 25 micrometer. Nucleus is same as trophozoite in both. Nuclei 1 to 4 in number in case of histolytica, while 1 to 8 in number in case of coli. Chromatid body thick bars with rounded ends in histolytica, while filamentous and thread-like ends in coli. This figure shows Entamoeba coli trophozoite iron hematoxylin stain, which shows nucleus with coarse peripheral chromatin and abundant food vacuoles in the cytoplasm containing fecal debris, while the figure B shows cyst iodine mound containing several nuclei. Now coming back to the morphology of Giardia, morphological forms are described in detail under lab diagnosis. Okay. Now life cycle. Host Giardia completes its life cycle in one host. Infective form cysts are the infective form. Mode of transmission: man acquires infection by ingestion of food and water contaminated with mature cyst or rarely by sexual route, mainly in homosexuals. Development in man. Excistation: two trophozoites are released from each cyst in duodenum within 30 minutes of entry. Multiplication: trophozoites multiply by longitudinal binary fission in the duodenum. Adhesion: trophozoites adhere to the duodenal mucosa by the bilobe adhesive ventral disc. In active stage of the disease, the trophozoites are directly excreted in diarrheic stool due to slowing of the intestinal epithelial cells every 72 hours. Encystation: gradually when the trophozoites pass down to the jejunum, encystation begins, which involves retraction of the flagella into the axoneme, followed by the formation of the cyst wall. On maturation, nuclei divide to become 4. The cysts are excreted in feces, can survive in the environment, and are infective to man. Pathogenicity: infective dose: as few as 10 to 25 cysts can initiate the infection. Risk factor: children are more commonly affected. Other high-risk groups are elderly, deliberated persons with poor hygiene, and immunodeficient individuals. In this figure, we can see the life cycle of Giardia lamblia. Man acquires infection by ingestion of cyst contaminated with food and water. Excistation in duodenum. Trophozoites released. Trophozoites multiply by longitudinal binary fission. Trophozoites adhere to duodenal mucosa. Trophozoites released to lumen. Trophozoites in jejunum. Encystation. Cyst passed in feces, and again another man can acquire infection by ingestion of the cyst. However, it does not appear to be associated with HIV or AIDS. Okay. Now, pathogenic form. Trophozoites are the pathogenic form. They adhere to the duodenal mucosa, cause disruption of the intestinal epithelium that leads to increased permeability and malabsorption. Trophozoites do not invade the mucosa but feed on the mucous secretions. Malabsorption may be of various types, such as malabsorption of fat, steatorrhea, leads to foul smelling, profuse frothy diarrhea. Disaccharidase deficiencies, example lactose, xylose, leading to lactose intolerance. Malabsorption of vitamin A, B12, and iron. Protein losing enteropathy. Antigenic variation. Giardia undergoes frequent antigenic variation due to cysteine-rich protein on its surface called as variant surface protein VSP. This helps the parasite to evade the host immune system, which leads to persistence of infection resulting in chronic and recurrent illness. Clinical features. Clinical course of giardiasis can be divided into three stages: asymptomatic carriers, acute, and chronic. Asymptomatic carriers, most infected persons are asymptomatic, harbor the cyst in the gut, and spread the infection. Acute giardiasis incubation period varies from 1 week to 3 weeks. Common symptoms include diarrhea, abdominal pain, bloating, belching, flatus, and vomiting. Fatty diarrhea, steatorrhea. Diarrhea is often foul smelling with fat, cellular exudate, and mucus, but no blood. Giardia is an important cause of traveler's diarrhea. Third, the chronic giardiasis, it may present with or without a previous acute symptomatic episode. GI symptoms include recurrent episodes of foul smelling diarrhea, foul flatus, sulfurous belching with rotten egg taste, and profound weight loss leading to growth retardation. Extraintestinal manifestations have been described, such as urticaria, arthritis, anterior uveitis, salt and pepper retinal changes. Now coming on to lab diagnosis, stool examination. Stool microscopy is considered as the gold standard for diagnosis of giardiasis, which detects cysts and trophozoites. Trophozoites adhere firmly to the duodenal mucosa by adhesive discs, leading to intermittent shedding. Hence, repeated stool examination, at least 3 samples collected on alternate days within 10 days, should be done. Pus cells or blood RBC will never be seen in stool microscopy in case of giardiasis. If found, it suggests alternative diagnosis. Sensitivity varies from 60 to 80% within one stool and more than 90% after 3 stool examination. Concentration technique like zinc sulfate flotation or formalin ether sedimentation methods are employed to increase the chance of detection. Duodenal sampling. If the stool examination is negative, then direct duodenal samples like aspirates obtained by enterotest or biopsy done by endoscopy should be processed. Permanent stains such as trichome stain can be used to demonstrate cyst and trophozoites in stool. Trophozoite. Presence of trophozoite indicates active stage of the disease. They are better appreciated in saline mount and permanent staining, but not in iodine mount. Measure 10 to 20 micrometer in length and 5 to 15 micrometer in width. Shape in front view, it is pear-shaped or teardrop or tennis racket shaped, and laterally it appears as a spoon sickle shaped. Motility, it has falling leaf-like motility. It is bilaterally symmetrical, bears the following structures: one pair of nuclei, adhesive or sucking disc, phyllote at its ventral surface, 4 pair of flagella, and pair of axonemes, which are intracellular portion of flagella. Cyst. Giardia cyst is oval shaped, measures 11 to 14 micrometer in length and 7 to 10 micrometer in width. It contains 4 nuclei and axonemes. They cannot differentiate active disease from carriers as they are passed in stool in both. Now coming on to Giardia lamblia schematic diagram. It contains a sucking disc, 2 in number, nuclei 2 in number, central karyosome. It contains an axoneme, flagella 4 pair, and parabasal bodies. Uh, in trophozoite lateral view, we can see the sucking disc, nucleus, and flagella. And in the cyst diagram, we can see the cyst wall, axoneme, and nuclei, which are 4. Now the entero test or sink test, it uses gelatin capsule attached to a thread containing weight. One end of the thread is attached to the outer aspect of the patient's cheek, and then the capsule is swallowed. Capsule gets dissolved in the stomach, releasing the thread, which is carried to the duodenum. It gets unfolded and takes up the duodenal samples. 4 hours later, the thread is withdrawn and shaken in saline to release trophozoites, which can be detected microscopically by wet mount or permanent stain smear. The entero test is useful for other upper intestinal parasites such as Strongyloides, Cryptosporidium, and Clonorchis. Histopathology. Endoscopy guided duodenal biopsy tissue can be processed by touch preparation and stain by Giemsa stain to demonstrate the trophozoites. In these figures, we can see the cyst of Giardia lamblia. A shows the saline mount, B shows the iodine mount, C shows trichome stain, and D shows direct immunofluorescence assay. In these figures, we can see the trophozoites of Giardia lamblia. A shows the saline mount, B shows trichome stain front view, C shows merthiolate iodine formalin MIF stain lateral view, in which we can see the spoon-shaped structure, and D shows Giemsa stain mucosal imprint, which is of front view. Now this is the anterior test equipment showing the duodenal capsule. It has a gelatin capsule containing the thread with a weight attached at the other end, and end of the thread with which the thread will be attached to the patient's cheek has a hook-like appearance. Now, antigen detection in stool coproantigen, ELISA and direct fluorescence antibody test DFA are available using labeled monoclonal antibodies against cyst wall protein antigens. Both the tests are highly sensitive 90 to 100% and specific 99 to 100%. They are very useful in microscopy negative samples and also in outbreak situations. Rapid ICT example triage parasite panel has been developed that simultaneously detects antigen of Giardia alpha 1 Giardin antigen, Entema histolytica and Cryptosporidium, which are with comparable sensitivity and specificity like ELISA. Antibody detection. Both indirect fluorescent antibody IFA and ELISA formats are developed to detect antibodies in the serum, but unlike microscopy and antigen detection, presence of antibody cannot differentiate recent and past infection. Hence, serology is the only helpful for epidemiological purpose for estimating the prevalence of infection. Culture. Giardia can be cultivated in axenic media like diamonds media used for Amoebiasis Giardiasis. Culture is done for research purpose and to prepare the antigen. Molecular methods. Detection of Giardia nucleic acid in stool and environmental samples water by polymerase chain reaction PCR or by gene probes is highly sensitive and specific. PCR can detect as low as 1 to 2 cysts in sample. Biofire film array is a fully automated commercial PCR system from Biomedics. The gastrointestinal panel is used to detect common bacterial, viral, parasitic like Cryptosporidium, Cyclospora, Entema histolytica, and Giardia diarrheal pathogens. Molecular typing can detect genotype and assemblages performed by sequencing several genes such as the glutamate dehydrogenase GDH and beta-giardin BG gene. Radiological finding. Fluoroscopy may reveal hypermotility at the duodenal and jejunal levels. X-ray after barium meal may reveal non-specific irregular mucosal thickening with large dilated loops of hypotonic bowel positive in 20% of the cases. Barium meal may interfere with the stool examination, so stool samples should be collected before the barium meal. Giardiasis treatment. Tinidazole 2 gram once orally is considered as the drug of choice. Metronidazole for 5 days or nitazoxanide for 3 days is given alternatively. Furazolidone is given to children and auranofin paromomycin can be given in pregnancy. In patients with AIDS and hypogammaglobulinemia, giardiasis is often refractory to treatment. Prolonged therapy with metronidazole for 21 days has been successful. Metronidazole resistance has been reported in Giardia. Auranofin stain is shown to be effective. Prevention. Giardiasis can be prevented by improved food and personal hygiene, boiling or filtering of potentially contaminated water, and treatment of asymptomatic carriers. No vaccine is currently available. Now, other intestinal flagellates of minor importance. There are a number of intestinal flagellates which are harmless commensals of human gastrointestinal tract, like Trichomonas tenax in mouth, Pentatrichomonas hominis in large intestine, Chylomastix mesnili in large intestine, Enteromonas hominis in large intestine, Retortamonas intestinalis in large intestine, and Dientermoeba fragilis. It is an amoeboflagellate, differs from other flagellates as it bears internal flagellum. It is a harmless commensal in intestine. Occasionally has been reported with association with mucus diarrhea. Okay, so this completes our part 1 of the chapter. Part 2 will be continued in the next video. Meanwhile, like and subscribe. Thanks for watching.